It's truly a pleasure to be talking to everyone today. I'm Greg Yanik from the University of Michigan Medical Center, and I'm direct the stem cell transplant program here at the University of Michigan. We have a great team here at the University of Michigan, but we also have a great team nationally that I work with. I've been proud of the work that pediatric oncologists across the country and world have done over the last 30, 40 years in terms of improving the survival rates for neuroblastoma. I finished my fellowship uh, at Cincinnati Children's Hospital in 1991. At the time that I finished my fellowship, the 3-year, what we call disease-free survival rates for children diagnosed with neuroblastoma was at best 20%. Here in April of 2025, if you look at our current modality of therapy, we're up to close to 60%. And in selected cases, it could be higher. Obviously, in selected cases, it can be a little lower. But we've literally not just doubled, but tripled the survival rates for our patients that are diagnosed with our children that are diagnosed with neuroblastoma just during my career. Here at the University of Michigan, I work closely with my oncology colleagues to serve as their arm for bone marrow transplant for children with neuroblastoma. I also direct our MIBG therapy program here at the University of Michigan. I've been integral to the neuroblastoma stem cell strategy group, first within the children's cancer group and then within the children's oncology group over the last 30 plus years, working with a number of talented investigators in helping to design many of the clinical trials that you as parents and your children may have been part of. It truly is a great team, and I've been blessed to have been a part of this entire team. When I look at the goals of stem cell transplant in high-risk neuroblastoma, I think of two goals. Where have we come from and where are we going to? The first goal is where we've come from. And from the late 1980s, 1990s to present, the goal of stem cell transplant was to serve as a platform for delivering high-dose chemotherapy to patients as, quote, consolidation after their initial several rounds of chemotherapy called induction. Where the goal is now, that I see potentially for stem cell transplant, is not to become just a platform for high-dose chemotherapy, but to become a platform for immunotherapy, to become a platform for novel approaches that we can take cells, stem cells, manipulate them, your own stem cells, use specific cells called CAR T cells or NK cells to then add a whole novel strategy on top of the entire transplant platform. Now, let me just go back then to the start. The initial transplants for neuroblastoma started in Europe and in North America in the 1980s. In the 1990s, a landmark trial was done. I still view it as one of the landmark clinical trials in all of neuroblastoma therapy. The trial was run by Kate Mathey. The trial was named CCG 3891. It was published in the New England Journal of Medicine. I believe it was 1997. And the way the trial ran was this. It was a fairly large trial also. It took children who had high-risk neuroblastoma. Everyone went through multiple courses of chemotherapy and induction, and then half the patients were randomized to receive 3 additional courses of chemotherapy, and the other half were randomized to receive a single bone marrow transplant. The survival rate for the patients that had the single bone marrow transplant was significantly higher than for those patients that just had the extended chemotherapy. For those children that underwent consolidation therapy with a single bone marrow transplant, the 3-year event-free survival or disease-free survival rate was 34%, compared to just over 20% for those children that just went on to get extended chemotherapy. It was on this landmark trial, CCG 3891, that bone marrow transplant truly became a foundation. A lot of people ask me, though, what were they really doing? I tend to view bone marrow transplant in the 1990s, 2000, 2010s, all the way up until now, as just a larger sledgehammer. If you think of it as follows, in fact, as a parent, if you're listening to this talk, Think of a ladder. Every rung on the ladder is a certain level of chemotherapy in terms of the intensity of chemotherapy. You can go up multiple rungs on this ladder, basically dose intensifying the chemotherapy. The chemotherapy that you currently get in the first two courses of induction therapy certainly within Children's Oncology Group, it's not low. It's several rungs on the ladder up. Courses 3, 4, and 5 of induction therapy within the COG model is even a rung or two higher. And then imagine transplant, where now you've gone up several rungs even higher above your induction level in terms of the amount of chemotherapy you're getting. What does that mean in English? What that means in English is that when you're up 3, 4, 5 rungs on the ladder, you get chemotherapy, the blood counts go down. They'll stay down for a week or two, and then they'll gradually come back up. When we dose intensify chemotherapy for transplant by going up several rungs on that ladder of intensity, now the blood counts will go down, but they'll never go down unless you literally rescue the body with your own stem cells. In essence, the way that transplant has been used for the last 30 years is as a platform to try to get rid of all the weeds in the lawn, not by individually plucking up the weeds with that little metal prong thing or by you spraying with Roundup, but by literally taking out the entire lawn and reseeding. The actual stem cell process itself, where we put the stem cells in, it doesn't do anything to treat the neuroblastoma. It's just a way of rescuing the marrow. And again, when you think of the role of transplant over the last 30 years, just think of a ladder. Think of the fact that with every round of induction chemo you get, you're up about 3, 4 rungs on that ladder. This is not low dose chemo. You're up there 3, 4 rungs high. But now we take you up to rungs 5, 6, 7 high. And by doing that, we're literally, blood counts will come down. They won't stay down unless we literally reseed. Transplant process is a reseeding. I always tell parents when I'm sitting there talking about transplant to literally think of weeds in a lawn. And as I said, we're not plucking up the weeds with that little metal prong thing. We're not spraying them with Roundup. No, if you do that, you break the roots off, and the neuroblastoma still comes back. No, we just give high dose chemo, take out the entire lawn, and then reseed. There have been multiple trials since Kate Mathey's landmark trial, CCG 3891, run in both Europe, in Japan, Korea, United States, North America, within Children's Oncology Group, that have now all shown the benefits of doing a autologous stem cell transplant as what we call a consolidation after induction chemotherapy. I always think of neuroblastoma, for the parents listening, I think of neuroblastoma therapy right now in blocks, 3 blocks of therapy. The first block is induction chemo, and that's to get the disease under control. Right now, within the Children's Oncology framework, it's 5 courses of chemotherapy. The second block of therapy is called consolidation. Within the Children's Oncology Group framework, that's 2 tandem transplants 6 weeks apart, followed by radiation to what we call primary disease. And then the third block within the Children's Oncology Group framework right now is maintenance therapy, which parents now know as immunotherapy, where they get that antibody therapy. So as a parent, think of neuroblastoma therapy as 3 blocks. The first block takes about 6 months to go through. The second block with the tandem transplants and radiation takes about 6 months to go through. And that third block with the antibody or immunotherapy takes about 6 months to go through. From start to finish, if you're looking at this as a race, it is a marathon race. It's about 18 months from start to finish. What we're really doing, though, and what we've learned with neuroblastoma is that this is an incredible tumor. We need all modalities to try to beat it. So thus we have high dose chemotherapy during induction. We have even higher dose chemotherapy during transplant. We bring in radiation. We bring in surgery after the 4th cycle of induction chemotherapy to take out the bulk tumor. We bring in antibody therapy at the back end. We literally bring in all aspects of modern oncology therapy to try to confuse this tumor and to try to get rid of it. The first goal that's been used over the last 30 years was to use transplant as a platform for high dose therapy, high dose chemotherapy, higher doses of chemo that we could ordinarily give, and then the transplants are rescue, reseeding. Where I view transplant going, the second goal is going to be as a platform for giving novel cells, for giving novel targeted therapy back to patients. This could be a whole nother talk, but a number of programs around the country are giving what are now CAR T cells or NK CAR cells. These are specific T cells, specific type of stem cells that are grown in a way to target a patient's own neuroblastoma. They're hired killers, cells that are just designed to target just neuroblastoma. This is what I view as potentially the platform for stem cells in the future, to be using stem cells, to be using T cells. T cells are immune surveillance cells in our bone marrow, to be reprogrammed to target just specific proteins on the neuroblastoma, and then to give those cells, stem cells, T cells, back to patients to target their tumor. Why do I say that's the future? Because I think we're starting to see that transplant can only take us so far. We're also starting to see, as many of the parents out there who listen to this are aware of, if they've been through transplant, all the side effects of transplant. You know, it's not for the meek of heart, both as a patient and as a caregiver. The side effects, the toxicities of the current transplant as we do it now, this high dose chemotherapy, they're real. The mouth sores are real. The potential for other organ complications is real. If you're a parent that's been through transplant and know about some of these terms, TMA, VOD is irritation of the liver. It's real. And as parents said, as one parent told me, they said, Dr. Yanik, you told me that they'd have sores in their mouth and potentially sores in the intestines. I didn't realize that these sores could go from cheek to cheek. And thus, right now, we're looking for ways to actually optimize how transplant works while minimizing all the short-term acute complications and long-term downstream complications. And thus, to give you a 10-minute answer to a short question, what are the goals for transplant? The first goal has already gotten us to where we are, to approximately a 60% disease-free survival, where we use transplant as a platform for high-dose therapy. But the future goal is to get that 60% up to 100%. And now it may be where we use these bone marrow cells, stem cells, or T cells, to use them to reprogram them to be specific targeting agents to target a child's neuroblastoma.